Finance and Policy Committee for today, Thursday, January 31st, 2019. We do have a quorum. And members, today we're going to begin with a presentation on the function of pharmaceutical benefit managers, and then we will be taking up Senate File 278. Senate File 278 will be placed on the table. After discussions today, there will be an opportunity for stakeholders and members to draft amendments and talk with committee members. We will renotice the bill when we believe there's been sufficient time and engagement, and we'll take amendments at that time. I know, Senator Marty, you had some interest in amendments, but we'll do an author's amendment today, and we'll ask for other members' amendments when we take it off the table, because we believe there's significant work to do on this bill. And so with that, I would like to welcome up Ms. Melody Schrader. She is with the Pharmaceutical Care Management Association. Welcome to the committee, Ms. Schrader. Please state your name for the record and proceed.
Good afternoon, and thank you very much. My name is Melody Schrader, and I represent the Pharmaceutical Care Management Association, which is better known as PCMA, and we are the National Association for Pharmacy Benefit Managers, which are better known as PBMs. So now that I've got all the acronyms out of the way, I'll try not, if I use another one, though, please make sure you stop me. Madam Chairman, members of the committee, thank you so much for allowing us this opportunity to talk a little bit about PBMs before you get into the meat of your discussion today. And I also want to thank you on a personal note for having me here, because you have made me the coolest aunt for my niece Izzy in Texas. Last night upon arrival, I don't know if you all know this or not, but they're talking all over the country about you guys' weather. Did you guys know that? I mean, everywhere. So when my niece found out I was coming, she thought for sure that I was going to turn into a snowman. So last night, some folks at the hotel were so gracious. Oh, wait, I have to tell you this first about my 40 below pin. So I went to Fairbanks, Alaska a few years ago in the summer. It was 100 degrees, but they put you in a box where it's 40 below, take your picture and take $15, and they give you this pin. You guys could make a fortune, right? A fortune. So I'm looking for a pin that says Minnesota 30 below. If anybody finds it, I want it. But anyway, last night some nice folks at the hotel gave me a hot cup of water, put my little coat on and my hood and my gloves, and I went outside and I threw it up in the air and it became ice. Oh my gosh. So I sent that video to everyone I know down south. Just so you know, I am a very cool aunt now. So thank you, not only for the opportunity to talk about PBMs, but the opportunity to be here and appreciate the weather that you all are having. And I know you all are excited about the fact it's going to warm up, and we're going to talk about something else on the news in the next few days. So again, thank you so much for allowing me. And if you don't mind, I've got a couple of prepared remarks, and then I'll be happy to take questions at any time during the presentations today. As I said, I am with PCMA, and I represent pharmacy benefit managers. So PBMs exist to meet the specific needs of our clients who pay for the drug benefit. Today in the industry, we've been around for about 40 years. We've got a track record of clinical and cost management innovation. Initially, PBMs primarily processed claims. But as drugs became more complex, expensive, and an integral part of our healthcare delivery system, our clients asked and now demand tools to manage that part of the benefit. PBMs offer a wide array of services that provide proven tools because our clients have demanded them. These tools are widely recognized as key drivers in lowering prescription drug cost, increasing outcomes, and access to these life-saving drugs. If I could, I'd like to pause for just a moment and take a little time to talk about the relationship between the PBM and the client, because it's an important part of the policy discussion that often gets lost in this critical conversation. PBMs are vendors. We have a business-to-business relationship with the entity offering coverage. Whether it is a large self-insured employer, a health plan, a labor union, they are the ones designing the benefit. The plan sponsor determines how it will be administered, Every detail is outlined in a contract between those two sophisticated entities. These services are often procured in a complex and competitive RFP process. With approximately 80 different PBMs in the marketplace, the PBM industry is highly competitive. The plan sponsors have a variety of choices when considering how best to manage their pharmacy benefit. Whether it is a large employer negotiating for these services or a regulated health plan, they are making decisions based on a finite amount of money. The employer wants to provide the benefit package that best suits his employees and allows him to retain a productive workforce while still preserving the capital needed to operate his business. The health plans must be able to balance the cost of the benefit with the amount of the premium that must be charged. PBMs reduce drug costs by encouraging the use of generics and affordable brand medications. We offer programs that reduce waste and increase therapy adherence that improve health outcomes through plan design, clinical management, step therapy, and drug formularies. We work with our clients to ensure that their members and employees have access to necessary medications through a variety of high-quality pharmacies, including retail, community, mail order, specialty pharmacies, amongst others. We manage high-cost specialty medications, negotiate rebates from drug manufacturers, and discounts from drugstores. PBMs have developed a number of tools that we make available to our plan sponsor. The clients evaluate the various options and structure their drug benefit to ensure appropriate use of resources. PBMs contract with over 65,000 network pharmacies to ensure patient access to prescription drugs. We monitor drug safety and alert pharmacists to potential drug interactions. PBMs provide highly efficient mail service that offers safe and cost-effective home delivery of medication. In addition to our pharmacy networks, PBMs use a variety of other tools to encourage the best clinical outcomes for patients. These include drug utilization review and disease management programs, which are designed to improve medication adherence. For example, PBMs improve drug therapy and patient adherence in diabetes patients by helping to prevent heart failures, incidence of kidney disease, strokes, and amputations. PBMs aggregate the buying power of our clients and negotiate discounts from manufacturers of drugs that compete with therapeutically similar brands and generics. These price concessions, in the forms of rebates negotiated by the PBMs on behalf of our plan sponsors, significantly lower the cost of drugs. As a result of the PBM's role in negotiating discounts from manufacturers, PBMs have been able to keep drug costs down, and the growth in net prices from prescription drugs continues to fall. PBM lower costs for patients and payers. According to researchers, PBMs help patients and payers save $941 per enrollee per year in prescription drug cost alone. That equals $654 billion over the next 10 years. Plan sponsors use these savings to benefit patients by lowering premiums or deductibles. PBMs save plan sponsors and consumers an estimated 35% compared to expenditures made without a pharmacy benefit manager. For example, PBMs were able to negotiate a savings of more than $400 per pill on the expensive but life-saving Hep C drug. PBMs have a proven track record of delivering high-quality, affordable benefits that address the individual needs of our clients and patients. But it is our clients who decide which tools to use and how best to use those tools to suit their needs and the needs of their employees or members. As I mentioned earlier, we rely on our pharmacy network to ensure our clients' employees have access to the drug benefit. Independent pharmacies are an important part of the supply chain. In order to strengthen their bargaining clout in negotiations, 80% of independent pharmacies hire Pharmacy Services Administrative Organizations, or PSAOs. These PSAO companies, like AmerisourceBergen, McKesson, and Cardinal Health, provide many services to independent pharmacies, including pooled purchasing power, negotiated reimbursement rates, inventory, and back office services. When a person goes into the pharmacy with a prescription, they often think the cost of the amount of that drug is their copay. But as you, as policymakers, know, that isn't the case. The drug manufacturer sets the price of the drug, but manufacturers don't distribute the drug. That is done through a wholesaler. The wholesaler may be the PSAO, or they may work with the PSAO so that pharmacies can purchase the drugs for resale. The pharmacies also negotiate rebates and discounts through their wholesaler or PSAO. The pharmacist stocks the drug, and the patient pays his copay, and the PBM, on behalf of the health plan, adjudicates the claim and pays the pharmacy. I know I've been giving a short time to talk about a complex issue, but I want to thank you very much for allowing me to be here and very much for making me the coolest aunt in Texas. I'll be happy to answer questions now or later at your pleasure, Madam Chair.
Members, we have time now for questions, but as we hear the bill, there might need to be some other technical support. So, go ahead. I'm going to go with Andrea's list. Senator Marty.
Madam Chair, ma'am, you said you've been working to save customers money, and I think you said 35% over what somebody would get a drug for without a PBM. Could you tell me the range, if certain drugs, some of the drugs that are more costly, the range you have between the lowest price one of your customers pays for that drug versus the highest price another customer would pay from one of your PBMs? Just as an illustration, just could you give me one?
So
Ms.
I'm
Schrader.
going to, pardon?
We go through the chair. I apologize. Ms. Schrader.
That's all right. I apologize. I will not make that mistake again. Thank you, Madam Chair. I want to make sure I understand your question because I think it could have a couple of different directions. If you're talking about the different copays that a patient pays, you're talking about the reimbursement rates.
Right, Madam Chair, the net price that the health plan or the employer or the patient would be paying for whatever pharmaceutical. If one of the PBMs in Minnesota is selling to 5 different customers, 5 different health plans, 5 different whatever packages, what's the widest range you might expect between what the highest paying customer would be paying for it and the lowest paying customer? In meaning both the copay and all the other payments, including the rebates and everything else. What's the range?
So I'm afraid, and I just made a promise, didn't I?
Please.
I apologize.
Please proceed.
Madam Chair. So I think I do understand your question. First of all, those are private contracts, and so I am not privy to that specific information. We are in a trade association and would be in violation of just about everything my attorneys tell me is bad in the world if we knew that information. So I think what you're trying to get to, though, I may be able to address in a more generic fashion if you would allow me. I think what you're saying is that individual contracts may reimburse at different rates, and I think that is an accurate statement. And I think that comes because, as I mentioned, there are a variety of clients in the marketplace. We may have, let's say, a self-insured company at 100 people. He may have a very different way he wants to approach his benefit and the way he reimburses than, say, a health plan that has 50,000 covered lives or an employer that has 100,000 covered lives. So the reason there are so many different reimbursement rates in the marketplace is because there are indeed so many different buyers and sellers in the marketplace. And I think it's economics at work when you see those varying prices.
Madam Chair,
Senator Marty.
again, I understand you don't have, and I didn't ask for a name of any drug or anything or any one of your PBMs, but just was curious what you think the range would be between what the lowest paying customer, whether it's a 100 employer with 100 patients in their plan versus the 50 or 100,000. What's the lowest price versus the highest price, the total net price, net of all copays, rebates, other kind of collateral payments? What's the net difference, would you guess, in one of the higher ones that have more variation? Could you give any estimate of that?
Ms. Schrader.
Thank you, Madam Chair. You'll get me trained. I could not, you used the word guess, and that would be reckless on my part. I could not do that. All I can tell you is that I know there is a variety of reimbursement rates based on the clients and based on the pharmacies themselves. and what kind of negotiations they have. If you'll recall, I did mention the PSAOs. So there's not just one, there are a variety, and they gather groups of independent pharmacies together all across the country. Some of them are national in scope, some of them are regional in scope, and they make contracts based on the interest of their entire pool of pharmacies. I was in another state, Senator, recently, where the independent pharmacist himself actually testified that the contracts that they have are national in scope, the one that he's involved in. He said it may be good in 48 states, but it might not be good in 2 states. If he happens to be in those 2 states, that's unfortunate. So then you ask yourself, well, why would he stay in that contract, right? Because I asked myself that. But there are a lot of services that the PSAO offers that particular pharmacist may need access to in order to stay profitable. There are lots of reasons why a pharmacy is profitable. Their resale of drugs is often one, maybe the main one, but there's also other aspects to why they would be able to negotiate one price over another.
Madam Chair, just one more question.
Senator Marty, thank you.
Thank you, and Ms. Schrader. I guess then the last question I might have is, who does know? I know the PBM knows what they're charging each customer for it, and they negotiate that, but I talked to a number of customers, whether health plans or pharmacists or others, and they have no clue what anybody else is paying. They're just told, we've given you the best possible price, and I just kind of wonder, because I've never seen any consumer transactions where one side knows what everybody's paying in their circle and the other side knows none of what anybody's paying except here's the price they're telling us and it's the best price we can get. Is that, would you dispute that that's the way it works?
Ms. Schrader?
Thank you, Madam Chair. So yes, I think I might take some exception with that. So again, I go back to, and I think you're referring to independent pharmacies as opposed, you said health plans, but I'm not sure that we're talking about health plans because, as I said, health plans are sophisticated buyers. They are sitting a table, and I've always imagined it's a table something like this, with a lot of consultants sitting next to them, negotiating the finer points of a contract, because between a health plan and a PBM, that's a business-to-business contract with sophisticated players. I expect that both sides know exactly what they want to know in those contracts. I think the contract that you're referring to is the contract with the pharmacy. And again, you've assumed that the PBM is always negotiating, or not negotiating in your words, handing a contract to this independent pharmacy. That is not the case. 80% of the independent pharmacies in this country negotiate all of their contracts with the PBMs through a PSAO, which again is a aggregator of these pharmacies. They are also a sophisticated business model. And as I mentioned, some of the names you would recognize almost immediately: AmerisourceBergen, Cardinal, McKesson. Even if it's a regional PSAO, those PSAOs are negotiating and taking services from these big players as well. So there is a lot of sophistication in the supply chain, and I want to make sure that I've made that point.
Madam Chair, I did mean health plans as well, because I get the sense that you have one side of the table knowing what other health plans are paying and what that health plan you're negotiating with them with, but the individual buyer may not, no matter how sophisticated they are, they may not know what anybody else is paying. And I recognize that a lot of pharmacies, most pharmacies, I assume almost all, are buying through somebody who's working with a whole chain or a whole group of independent ones, but I hear from a lot of people who feel that they're totally in the blind in terms of what they are doing, or largely in the blind in terms of how they compare with somebody else. It's all secret.
Thank you. Senator Marty, is that?
It was
More of a
comment, but she can comment on
I-
the comment if she
I
wants.
appreciate that. We do have other members on the list, and we do want time to treat Senator Jensen's bill with respect. So Senator Abler, Senator Klein, and then Senator Kiffmeyer.
We're running low on time. I'll pass.
Thank you, Senator Abler. Senator Klein.
I'll also pass.
Thank you. And Senator Kiffmeyer?
I'm going to go ahead. Question I have for you is the mystery of the rebates and incentives. I understand quantity purchasing, the variations in contracts. Sometimes they're what's included in a contract, what is not. There's a whole variety of things that just contractually in general, I can understand that. What I find, though, is really puzzling in this whole thing is rebates and incentives. Why do they have a place, rebates and incentives, to who, incentivizing who? I've never gotten an incentive to me at all, so I've never gotten a rebate to me. So the consumers aren't. Who are these rebates and incentives going to, and how does that work?
Ms. Schrader.
Thank you, Madam Chair. You have asked a very complicated and long question, and I will try to be succinct as possible. So there was a court case a number of years ago that said that manufacturers needed to offer rebates as opposed to discounts. Okay, so, and that is a complicated and long discussion I would love to have with you offline, but let's just say that rebates have to be in the system because discounts are not allowed by the courts. So having said that, what I think you're really trying to get to is why do the rebates exist at all? So there's a couple of reasons. And where does that money go? Also an excellent question. So the rebates are obviously negotiated by the PBMs with the drug manufacturers. They're there for a couple of reasons. It's obviously to get to the first and foremost is to get to the lowest net price for that drug. So since the rebates are negotiated based on volume can't be measured until the drugs are sold, so that's why it's a rebate as opposed to upfront discount volume. Those rebates are then negotiated and paid based on the volume sold. So then that money goes back based on contractual arrangements. 90% of it goes back to the health plan. On average, 90% goes back to the health plan. I'll make that clear. It could, in a lot of contracts today, 100% of that money goes back to the health plan. Now, how does the health plan choose to use it is up to them. They can lower premiums, which is good for the entire population that they cover. So if they've got 50,000 covered lives, they can put it into their actuarial analysis and lower the premiums. And that is what most plans, I think, today choose to do. There is, I think, a lot of discussion in healthcare today about doing something which I think you were alluding to, which is point of sale rebates, which means, because let's go back to my example. So there may be 85% of all drugs sold are generic drugs and cost less than $50. 85% of all drugs filled. It's that 15% that we are now talking about. Those drugs that are life-changing, the drugs that are complex, they're big, they're biologics, they cost a lot of money. Those are the drugs that are often making the papers, and they're also, when a patient needs it, they need it, and we want them to have it. So then how do you manage the rebates on those drugs that cost more than $50? There are some companies today that are exploring whether or not you do point-of-sale rebates, which means the patient sees that at the counter. That's a complicated business analysis. It's a complicated system change. And I will tell you that it's way above my pay grade, but there are lots of people who are a lot smarter than me talking about whether or not that is the way to do it. And what you're really asking at that point is, do you raise the cost across the board, which is what you would do for premiums across the board, in order to solve that one problem with that one patient? And I think a lot of people are saying, yes, that is the way we want to do it. But there are still others who are saying that it is best to take those rebates and let them benefit the whole and reduce premiums. So I think that is a very, very big discussion, a very big philosophical discussion that's going on in boardrooms all across the country today.
Madam Chair, thank you very
Senator
much. I think I try to ask the question also because I think it's helpful to all of us to have more information about that area as well. But just to know that the plan for state government employees, since they are self-insured, so there are other large companies that are a self-insured plan, and they gain substantially, and they say it helps reduce premiums overall when they get those. But we don't know that all put it back into that or what they do with it in regards to those in that particular benefit. But thank you very much for the information. That was very helpful.
Thank you, Senator.
And Senator Draheim?
Thank you, Chair. I got a couple-part question, if I could, Chair.
Proceed.
Ms. Schrader, your PBMs that you work with, you do business from companies from all over the world, correct?
My association is only U.S.-based, but
But their suppliers to your people are all over the world, right?
I cannot say they're international companies, but I would suspect they are.
Okay.
Some of them, anyway.
So I guess part of my frustration in the 2 years we've been looking at this is the international community seems to get drugs a lot cheaper than we do here in the United States. And that's why we're here today. That's why we're trying to have this discussion. So I would assume if the manufacturers are global, which we know they are, and the prescriptions are chemically designed to be accurate, can you explain why the drug prices are so much cheaper in other countries?
Ms. Schrader?
Thank you, Madam Chair. Actually, I want to make sure we're clear. I represent the pharmacy benefit managers, so your answer would be better suited to pharma. So I'm going to be very careful about how I answer your question. That is a discussion that goes on, and we too agree that what we want to get to is the lowest cost for our clients and ultimately the patients. To get into the discussion of, and I will not get into the discussion of how we pay for research and development and how that differs from across the globe. You've asked one of the most complicated questions I've ever had in a hearing, because that's usually reserved for my friends at pharma. I will tell you that our companies look at that every day, and our goal is to figure out how to get the lowest cost possible on those drugs within the confines of the law of this country.
Thank you. Senator Draheim?
So do you have any suggestions on how we change those laws so we can get affordable drug prices?
Ms. Schrader?
Thank you, Madam Chair. I actually am happy to share with you a document that goes to some of our federal efforts on how to lower some of the cost of drugs in this country. But I don't think this is the appropriate place for me to get into it.
Thank you.
But thank you.
Thank you. Senator Nelson, and then Senator Hayden.
Thank you, Madam Chair. One, thank you for being here today. And I just have it is definitely tied to this bill, but it's not specific to this bill, but it's a more generic question that I'm hoping you can help with. When you negotiate with the drug company, you have, sometimes it seems that there could be the incentive to negotiate a higher cost on a particular drug because there is a larger rebate coming to the PBMs. And so the concern that I have is what prevents a PBM in having a contract for a particular drug that is of a higher cost with a particular company, because and then the PBM gets the larger rebate, which doesn't go, as I understand it, to the consumer. So there's a little bit of maybe some misaligned incentives there. I'm recalling an article I read in the Wall Street Journal maybe 2 or 3 years ago about this particular issue. And I'm just wondering if you can speak briefly about the role of rebates and their advantage or disadvantage to the PBMs, and what's the correlation between the amount of the rebate and the agreed upon drug price.
Ms. Schrader?
Thank you, Madam Chair. And thank you, Senator. And you're right, that's a very good question and very timely. So let me say a couple of things about that. All of my companies that I represent have said, all my PBMs have said, we want to get to the lowest net cost, period. We don't care if that's at the end or the beginning. We want to get to the lowest net cost. And the reason we want to get to the lowest net cost is because, as I stated earlier, 90%, and in some cases 100%, and increasingly more every day, it's getting closer to 100%, of those rebates go back to our clients. So whether we negotiate the rebates up front or we have the lowest net cost, then we don't care. What we want to do is get the best deal for our clients. So 90% of them don't stay with us anyway. They go back to the client. To your point on why they are important and why they exist, and I know there's been a lot of discussion about it, but you need to remember how we use those rebates. Those rebates are used because there are two drugs that are, and Senator Jensen, if I say this wrong, I'm going to count on you, keep me honest. They're therapeutically equivalent. So in other words, they do the same thing, but possibly in different ways.
Are you speaking of biosimilars?
Biosimilars or generics, or no, not. I'm talking about two drugs that they're not even similar. They accomplish the task, the end task, but they do it in different ways. So once we get two drugs in that class, which was the case with the Hep C drug, once we had two drugs in that class, what we could do then is go and say, you can't just charge $80,000 because that's what you said the price was. We've got another drug who will do it for less. And so once we were able to use those two drugs and have them compete, then we were able to bring down the cost by $400 per pill and nearly cut the cost of that treatment in half. It's significantly different today than it was the day that that treatment was first introduced. And it's because we use the rebates for formulary placement to negotiate that price down.
Senator Nelson.
I'll be brief. I know we're short on time, but I really kind of want to get to this rebate question. Why don't 100% of the rebates go to the client? I like the lowest net cost, but my question is the lowest net cost for whom? In other words, I'm looking for that lowest net cost for the consumer. And when I hear that 10% of the rebates do not go back to the consumer, but they go to the PBMs, that raises a lot of questions in my mind. Might only be 10%, but it could be a lot of dollars. And it kind of gets to that point that I'm talking about regarding PBMs using rebates to ensure the lowest net cost for the patient and not rebates back to the PBMs.
Ms. Schrader.
Madam Chair. Senator, you're exactly right. So 90% is the average. In many contracts that are being negotiated today, it's 100% of the rebates go back to the client. Then we get back to what I said earlier, actually, is when you say it goes back to the consumer. So it goes back in one of two ways, either at the point of sale to the consumer that is actually purchasing that one particular drug, which is very expensive, or the whole of those rebates go back to the client. For example, in a commercial health insurance plan, they go back to the client and they use it to reduce the premiums across the board. So it is really, so go back to, let me use a simpler example, which would be a large employer, because then it's their money, right? It's not, we're not going through the regulated entity. So they get to decide then, as they're offering the benefits, so they're sitting at the table offering that benefit, which means the employer's using their money to purchase that benefit. It is their decision whether or not they want to use those rebates. If they want to take 100% of them, that's something they would negotiate in their contract. If they left 10% on the table, it's because they forewent paying for another service. That's how those negotiations happen, because again, they're sophisticated parties. The money ultimately in a commercial plan goes back to the consumer in one way or another. It either reduces premiums or it goes to that individual consumer that is purchasing that high-cost drug. But it always goes back to benefit the pool of the risk pool.
So, Madam Chair, my last question, just a hypothetical to think about. So I'm thinking PBMs negotiate for the lowest net cost, but if all the rebates went back to the consumer, I'm just wondering, you know, in my own mind, why don't all those rebates go back to the consumer? You don't have to answer that now, but that's something I'm going to cogitate on here and try to understand. Why can't we get all those rebates directly back to the consumer? I like the fact that the PBMs negotiate the lowest price, but I want to make sure that the rebates go to the consumers.
Thank you. And Senator Hayden.
Well, thank you, Madam Chair. And cogitate, I'm going to do some cogitating myself, Senator. First of all, thank you for coming. I have like a really kind of simple question that I just asked my counterparts. Do we use PBMs and services like yours in, say, Canada?
Yes.
Ms. Schrader, yes, okay.
In the
But-
same,
I'm sorry.
Madam Chair, is it?
Thank you, Senator Hayden.
So would they have the same similar setup? You negotiate with government, or you negotiate with corporations? How does that work in Canada? Because it kind of gets at Senator Drahan's question about what we all kind of want to know on a very basic level, that you said you were in the best position to answer because you weren't big pharma. But how does it work? I mean, you're pretty smart and pretty articulate, but how does it work up there that their drugs are so much cheaper and ours is so much more? Do you just do a better job negotiating in Canada for consumers, or how does that work?
Ms. Schrader.
Madam Chair. Senator, actually, I can only say that I know that some PBMs work in Canada. I do not know the intricacies of how their operations work because none of our entire organization, as I said earlier, is U.S.-based. So I can actually try to find you that answer, but I apologize. I can't answer it today.
Thank you.
Senator Hayden.
Thank you, Madam Chair. And I would appreciate that because at some point we got to get to the bottom of it, and we really appreciate you here, and you're giving us the answers as best you can, as best you've been oriented. But at the end of the day, Senator Nelson and Senator Jensen's bill, Senator Draheim, everybody's kind of trying to get at the same issue, which is why does it cost so doggone much here, and then we could go, just a little bit north of here, same temperature, and get the same drug. and it costs so much less, literally just go across the border. So either something's going on that somebody isn't saying, or you're doing a much better job in Canada negotiating with drug manufacturers, or the gas is less there, so the truck that drives it to the pharmacy, and I know I'm kind of being facetious here, but that's at the issue here. That's what we're trying to figure out. And if we can't, you can see where this is going, and if we continue not to get these kind of answers and better understand it, then we're going to continue to try to figure it out our way. We're probably not in the best position to figure that out, but that's what the people gave us the job to do. So at some point, you're going to have to tell us something, or somebody in here, all these folks are going to have to tell us something, or we're going to start making some rules that is going to be not advantageous for you, which may not be advantageous for the consumer. But we got to get to the bottom of this.
Thank you, Senator Hayden. I'm going to take that as a comment, and I'm going to thank you. Ms. Schrader, if you'd like to take briefly a few minutes to close, and then we're going to move on to Senator Jensen's bill. So thank you.
All I would say is thank you all very much. You've had some very, very good questions. I can't see well enough to call everyone's name, but thank you all very much for allowing me to be here. Thank you for allowing me to answer some of your questions. I will try to get some additional information back to you. I apologize. I'm not versed in Canada's system, but we certainly will try to get some information to you, and I appreciate it. What I will say in closing, to your point, is that the pharmaceutical manufacturers set the price. We work from that point. And our goal every day is to make sure that we save our clients, the health plans, the union plans, the church plans, state employees, Medicare, Medicaid. Our goal is to save them money and get them to the lowest net price. We use a lot of tools to do that, and that is our goal. So I appreciate your all's concern. We too share your concern on the rising cost of drugs.
Thank you, Ms. Schrader. And now, if we could excuse you, if you'd stay close by, Senator Jensen. And members, the bill is in your packet. There is an author's amendment. We will take the author's amendment today and save the remainder of the amendments. We'll put this bill on the table so that members will receive notice and have the opportunity to vote to take it back up again. So, Senator Jensen, would you please move your bill and begin?
Thank you, Madam Chair. Senate File 278, I would move that bill.
Senator Jensen moves Senate File 278. Please proceed with your amendment.
I would also move the Amendment A3, which is essentially a technical amendment, and it also contains some clarification information regarding page 15 of the bill in regards to pharmacies having the opportunity in the context of a written protocol to substitute bioequivalent medications in situations where prior authorization might slow down the process.
Okay, Senator Jensen will ask you to explain that as you go through the bill. So members, Senator Jensen moves the A3 amendment. It is an author's amendment. All those in favor say aye. Aye. Opposed? Senator Jensen, your bill is in shape. Please proceed.
Thank you so much, Senator Benson, Madam Chair. This is Senate File 278, and I would like to specifically say thank you to Senator Benson and Draheim, as well as Senator Gary Dames and Melissa Wickland. Thank you. There's been a lot of hard work on this bill. Also, I would be remiss if I did not mention that Senator Klein and Senator Kiffmeyer and that Senator Abler and Senator Matthews have worked alongside of us a long time as we had the select committee moving forward as well. And thank you, Senator Draheim, for all your encouragement. I also would like to say thank you to Ms. Katie Kavanaugh for the writing that she's done, and Andrea Todd Harlan and Bailey Strand for their devoted work to this bill. Essentially, we're talking about a middleman, and if this were as easy as getting a gallon of milk from a cow to a grocery store, we wouldn't be here probably, but it's not so easy. So indeed, the milk from the cow gets taken care of and put into a cooling tank. Someone comes and picks it up. They drive it to the dairy plant. The dairy plant does the homogenization, pasteurization, packages it, and gets it to the grocery store, and we buy it. Pretty simple. In the world of pharmaceuticals, we've got this middleman called pharmacy benefit managers. In 1967, when they first became a player, it was shortly after Medicare and medical assistance had come in play. And essentially their role was to process prescriptions. And prescriptions were starting to come out a mile a minute because we were getting a lot more medications from the manufacturers because our drug industry really took off in the 1950s. But over the next couple of decades, with the advent of HMOs, we began to have more and more need and role for PBMs. So PBMs then started to work with payers, if you will, the health plans, the large employers, and they say, we can help you craft a formulary that will try to eliminate redundancy, that will try to provide consistency and also get you the best prices when there's more than one drug in a certain class. Initially, their efforts were to tier medications. After a period of time, they were able to say, we're going to simply slice and dice. And when they said, this drug doesn't get into the formulary, this one does, you can imagine that that was an easy scenario whereby a manufacturer of a drug would say, nuts, we really wanted our drug to be on the formulary. You can imagine what happens next. The manufacturer goes to the PBM and said, what do we need to do to get our drug on your formulary? Well, let's be creative. Maybe a rebate. How much? Maybe a little bit more than you're offering. And that's how it got started. So today, we're looking at a PBM bill. I'm going to try to run through it fairly quickly because I think we'll have more instructive conversation through question and answer than me boring you. So if you just a couple of things, 62D addresses HMOs, 62J addresses healthcare cost containment, and 62Q addresses health plan companies. Those are some of the categories of statute that we will be dealing with. So if you take the bill before you, what this bill does is it calls for pharmacy benefit managers to obtain a license. Generally, most players in the healthcare field are indeed licensed. I think I had a chance to talk to Ms. Schrader prior to her testimony, and she indicated that approximately 4 or 5 states call for licensure in the United States at this time, so we would perhaps be right around number 5. This bill also calls for the PBM to have a fiduciary duty to the health carrier. It also calls for PBMs to disclose rebate and pricing information to plan sponsors as well as the Commissioner of Commerce. And what we're looking at here is nothing more than the same thing that we've been doing for the last 2 years under the leadership of Senator Benson as we've tried to get transparency to literally infiltrate every level of healthcare. And that's what we're doing here as well. We're asking PBMs to provide pharmacies with current, up-to-date, maximum allowable costs because this has so much to do with the way they do business. We're asking PBMs, we're prohibiting PBMs from prohibiting pharmacists from disclosing information, if you will, the gag clauses. And I think in fairness to PBMs, I think that they're ready to let go of some of that contractual language already. In addition, Senate File 278 imposes some cost-sharing limits for consumers at the point of sale. It also has a clause in it that allows pharmacists to substitute therapeutically equivalent and interchangeable drugs in place of a prescribed drug, and I would be glad to sit for questions in that regard as well. Right now, we have 105 pages of statutory regulations for accident and health insurance in the books. We've got 12 pages of statutory regulations regarding nonprofit health plans. We have 41 pages of statutory regulations for HMOs. We don't license PBMs. So from the beginning of this bill to the end, what we're trying to do is we're trying to introduce a transparency that will make all the players more knowledgeable. And as they get more knowledgeable, they'll be able to ask questions. And as they ask questions, hopefully we start to drive the price down. I think one thing you won't see in this bill is you won't see pure price setting. That's not the kind of regulation that's here. We're looking at licensure and the same kinds of things we do with other players in the healthcare industry. So having said that, if I could, Madam Chair, I would like to call for the testifiers to come up. And after they're done, perhaps we could have a robust question and answer.
Okay, thank you, Senator Jensen. We have Dr. Jessica Arrett, and I believe it would be Dr. Gary Baylor. Hi, welcome to the committee. I am not sure who Senator Jensen would ask to go first, but please introduce yourself for the record and proceed.
Thank you, Madam Chair. Good afternoon, committee and Madam Chair. My name is Jessica Astrup Arrett, and I'm a pharmacist and third-generation owner of Astrup Companies. Our family operates 17 retail pharmacies, 4 long-term care pharmacies, and a specialty infusion pharmacy in central and southern Minnesota. I serve as a board member and work as a staff pharmacist in our community and retail locations. I work primarily in the Sterling pharmacies in Northfield and Faribault. Sterling was founded by my grandfather in 1952. He came to Austin, Minnesota from North Dakota to open a Walgreens agency store. He had $11 in his pocket and no connection to this area of rural Minnesota. The first banker that he met with denied him a loan, but the second banker liked him and helped him finance his first store. After a ton of hustle, relationship building, and mentorship, my grandpa grew a successful business that remains a staple in our small town today. My grandpa passed away in 2014, but he was always proud that the only loan he ever took was to open his first store. He was able to build his business by providing expertise to his patients, engaging with his community, and consistently offering a high level of care, or a high level of customer service. He went beyond the competition. He was known for delivering prescriptions via snowmobile when the local roads weren't passable, and visiting patients in the hospital when they couldn't make it in to visit him in the store. Times have changed. Our industry has become so complicated with so many entities involved, including pharmacy benefit managers, that make it increasingly difficult for our independent business to survive. Community engagement, excellent patient care, healthy business practices, all of this is no longer a recipe for success in independent business or independent community pharmacy. We can earn new patients, take excellent care of them, and build trust, only to be told one day that we can't fill their prescriptions. We can provide hours of counseling, visit patients in their home to ensure proper medication use, help them navigate open enrollment for Medicare and commercial insurance plans, communicate with their physicians and insurance companies, but we're not compensated for any of these services. We're forced to operate on narrower margins every year while providing more and more services. I thought it would be a good idea to come armed today with a few examples of how pharmacy benefit managers have made it more difficult for my patients to receive the care they need at a cost they can afford, and how PBMs have made it more difficult for our family to operate our mostly community or rural community pharmacies. These are real patients with real consequences to their health. The first example, one of my patients is an over-the-road trucker, often away from home for many days at a time. After struggling with medication adherence or compliance due to his life on the road, he faced some health challenges over the past 3 years. He ultimately required 4 cardiac surgeries, which dramatically increases pill burden, or the number of pills or medications he's taking every day. Our pharmacy worked with his wife while he was in the hospital for his first surgery to come up with a plan to streamline his care. One aspect of our care plan was to synchronize his medications so that they all came due ahead of time on the same day each month. This would allow him to pick up his medications in advance of his next stint on the road. His adherence improved, but he was no longer able to afford his copays because they all came due on the same day. We began looking at medication costs for this patient. We worked with his physicians to substitute one medication for a lower cost alternative. We identified a generic medication that was assigned a higher than necessary copay from his PBM. The copay was $75. I remember being questioned by his wife on this because she knew it was a generic product. I looked at my cost, was as transparent as I could be with her. The cost to me was less than $13. I didn't need to charge this patient $75, but that was the negotiated price. All of this planning and coordination with patients is what fills my cup as a pharmacist, but it isn't what keeps my lights on. The reimbursement on this patient's medications at the end of the day doesn't cover the time it takes me to take care of his needs and meet his needs. The reimbursement continues to decline every year. Patients aren't one size fits all, and neither are pharmacies. Some pharmacies strive to offer higher touch services to meet the needs of these complex patients. These services keep patients out of the hospital. They position pharmacists to be valuable members of the care team. Patients deserve a choice when it comes to pharmacies, and pharmacies deserve fair compensation for helping to truly manage patients' health. That's my first example. Second example, another issue we often see is patients being required to change medications because they changed plans or because sometimes it goes from 2018 to 2019, which is the case in this example. I had a patient who was well established on a product that worked for her. It was a brand name inhaler. Sometimes we can go and get a prior authorization in order to get a previous product covered. In this case, the PBM required the patient to change to a new brand name inhaler. This medication wasn't any less expensive to the patient, but the other one was no longer on formulary. So this patient was used to one particular inhalation device and was very nervous this January because she, after many years on this medication, had to make a change. Our pharmacist worked with the patient and eased her fears, but my question is, why is this necessary when the initial product was actually slightly less expensive and it worked well for the patient? Why is the PBM making medical decisions for a patient they've never met? Lastly, this just happened on Tuesday. One of our pharmacies received a call from a PBM that we're all familiar with. They were asking us to reverse a claim because their mail order pharmacy was attempting to fill the prescription. We called our patient to discuss because we have a close relationship with them, and the patient stated that she did not send the prescription to them. She didn't even know who the pharmacy was. They had simply intercepted it based on the data that they get in the background, that claims data, and tried to steer it to their own pharmacy. We encounter this business practice, sometimes called prescription trolling, time and time again because of the placement of PBMs in the transaction chain. Our pharmacies can meet the needs of patients from birth to death, including specialty and long-term care needs. Patients should have the choice to keep all of their medications in one place with a pharmacy team whom they trust. If we can meet all the needs of the patient, provide the necessary data to the PBM, it seems like the PBM should allow us to continue caring for our patients. I firmly believe that PBMs were started to do good and to contain costs. However, today that's not happening. They need scrutiny and visibility to ensure that the claim processing industry has fair rules of the road, and most importantly, to ensure that patient care is the primary focus. Thank you so much for the opportunity to speak with you today, and I'm definitely open to questions if you have them.
Thank you for your testimony. Senator Jensen.
Madam Chair, thank you. If I could just say thank you very much to Ms. Jessica Astrup, and then I would like to just provide one clarifying comment to her testimony. When it comes to asthma inhalers and metered dose inhalers, I think it's important for the committee to know that these inhalers don't all work similarly. There have been a variety of canisters and things like that. So sometimes it's a straight take a puff. Other times it's you have to cock it and puncture a little aluminum foil bag inside. So when a pharmacist has to switch a patient from one to another, and they're both trade name drugs comparably priced, and in this situation, Ms. Astrup clearly indicated that wasn't a savings to the patient. This is a big deal because all of a sudden the actual bioavailability of the drug going to that patient's lungs may be cut in half. And I see Senator Klein nodding his head because this is exactly the kind of patient that goes into the emergency room and then lands in a hospital bed so he can take care of them. So I thought that was a very poignant example that you shared. So thank you. And then I would turn to my next testifier, Mr. Gary Baylor.
Mr. Baylor, welcome to the committee. State your name and proceed.
Good afternoon, Chair Benson and Senate members of this committee. My name is Gary Baylor, for the record. I've been a pharmacist for the last 49 years, the last 35 of which I have spent doing primarily third-party contracting on behalf of individual pharmacies, smaller groups of pharmacies, and actually for some nursing home facilities that I have also consulted for. My wife and I live in Plymouth, where I've resided for the last 21 plus years. Knowing my time today is limited, I will get right to the point of why Senate File 278 that is long past due. I will get right to the point. Putting in place state transparency and oversight, as well as providing patients and payers with guarantees and vital information they need after what I have found over the years and continue to hear with respect to less than honorable activities being conducted by PBMs must be enacted now. I applaud Senator Jensen and Madam Chair, you and your colleagues' efforts to protect patient consumers and to rein in the PBM profit industry that I believe has a direct causal effect on the rising costs of medications and right now, at this point in time, putting many, many independent pharmacies out of business. As just a small side note, I called one of the stores that I consult for a couple of weeks ago. I had a 45-year-old pharmacist crying on the phone to me because he didn't know how he was going to pay his employees that week, one of the stores that I consult for. So just an example of how bad this has really gotten. These untoward practices have negatively impacted patients, plan sponsors, or the end payers, if you will, and the network of pharmacy providers across Minnesota. Allow me to highlight some of what I have learned over the past many years that continue to cause financial hardships and impact care for patients, plan sponsors, and pharmacy networks, all at the hands of the PBM industry. The first people that are impacted probably as greatly or more greatly than anybody is the patient that we try and serve from all of our pharmacies. These are the least educated portion of the triangle of these victims. They are the unsuspecting because they just take what comes and are basically do what they're told because they know no different. To provide a simple example, I direct your attention to the first cover letter and were the packets distributed? They were, okay.
Okay, and for the public, this information will be scanned and posted to our website.
Yes. This first example of what I am bringing to your attention that impacts patients greatly today are what's called patient clawbacks. A patient clawback occurs when a pharmacist submits a prescription that may cost him $8 or $9. The pharmacy benefit manager responds back with, I would call, a rather excessive reimbursement rate of, let's say, $40. But when that patient comes to the cash register to pay for that prescription, that patient is charged a $32 copay for something that cost the pharmacist $8, could probably have sold to that patient for cash for $12, $13, or $14. So the patient pays $32. The patient is paying more than what's been adjudicated, more than what the usual and customary fee would be by that pharmacy, and more than that patient's customary copay and or coinsurance. That $32 that the patient pays is left at the pharmacy till the PBM in the next remittance advice or billing and check that's sent back. That amount is probably redacted by $20 to $22, leaving the pharmacy with about a $2 profit and the patient being grossly overcharged. It happens time and again. And on this little example that I provided, and I have all the documentation to back it up, but I chose not to share that. I can provide it at your request. On 471 prescriptions, The pharmacy benefit manager in this case paid a negative $3,373. The copay for the patients on these 471 scripts was $11,768. The PBM paid nothing, but they're supposed to be paying this health benefit. The patient was fleeced by all of these additional copays, and the pharmacy in the end, for providing the service and filling the prescriptions for these PBMs and the plan sponsor, averaged $3.68 per prescription to fill and counsel the patient. I see this frequently, and it continues to happen. Second thing I want to talk about is steering, which is extremely rampant as well, and I think that was addressed a little bit earlier in the testimony. But I presented something here and put it in the packet that came from a newspaper out of state where a PBM, local pharmacies losing business from accidental third-party mailer. I did some investigative work into that. This happens to be in the state of Wisconsin. This was the third year in a row this happened. That's no accident. Patients become frustrated. They want to be served by their local hometown pharmacist that knows them, that understands them, that knows their family and the name of their pet dog, because that's the kind of relationship that's established with these smaller independent pharmacies. Pharmacist that's local knows their medications, knows their medication regimens, knows their physicians probably on a personal first-name basis, and can work with that physician and not try and do it with a PBM that's located 1,200 miles away, either on a phone or an email. This becomes complicated for patients whose doctors may have prescribed a medication that's not on a PBM formulary, and that was addressed again, such as the changes during mid-year. There are other examples that impact patients, but these are two of them that come to light. Plan sponsors are the ones footing the bills. They pay the bills. Common language among PBMs is that they only deal with the most sophisticated and senior leadership at a plan sponsor organization when negotiating. Based on my years of experience and the number of plan sponsors where I've sat in boardrooms and tried to explain contracts to them, that is not the case. And the reason it's not the case is because these contracts today are opaque, lack transparency, and again, as what was alluded to earlier, one side doesn't know what the other side is doing or getting or understanding. Okay. I've also got some information and some more examples that I've provided throughout this written testimony. I apologize for it being longer. I will always be at your beck and call anytime. My business card is attached and inside of each of your packets. You may call me anytime. You may email me. You may text me. And I will respond because I think this is something that's very necessary for the state of Minnesota. It's catching fire in other states. I would like Minnesota to be one of those leaders. Thank you very much.
Thank you, Senator Jensen. We do have two members of the public. I'd like to give them an opportunity to submit testimony as well. And members, just a reminder, we're not going to take a final vote on this today. So, Senator Hayden.
Thank you, Madam Chair. I got a question to kind of this point. And Senator Jensen, or Madam Chair, is there going to be opportunity for the PBMs to come down? I mean, these are really pretty egregious things that our testifiers are saying is happening to them in their businesses. Are we going to, Madam Chair, Senator Jensen, are we going to be able to hear from the PBMs that are, I know that we just had a woman here from somewhere, and we have a few others that I can see. Are they going to come down and be able to talk about their business practice or refute what our testifiers are saying?
And Senator Hayden, part of the reason we planned this to be two hearings so that we could get some of these complexities out front, and then as we had these individual meetings, these stories could be vetted against what the PBMs tell you in their office. When we come back, we will do amendments. We will ask the PBMs to be here at that time as well.
Madam Chair.
Thank you. Senator Jensen?
To the point.
Senator
Thank you, Madam Chair. Senator Hayden, thank you for your comment and question. Indeed, just as Senator Benson said, we do plan on having an additional hearing, but I think between now and then, I know that I've already set up meetings to meet with Optum, and I've also met with other PBMs. I think that in common speak, some of the things we want to be able to have discussions about over the next couple of weeks is things like gag clauses and clawbacks and direct and indirect reimbursements, the spread pricing, and I would like to give an example of that today if time permits, formulary and network exclusions, manufacturer rebates, marketing techniques, audit protocols that sometimes exclude various pharmacies, as well as the whole concept of an uneven playing field. So those are some of the things I think we plan on talking about. Thank you.
Thank you, Senator Jensen. I'm going to ask for Mr. Dave Renner and Mr. Bentley Graves to please join us. And members, we're hearing problems. So as we do good constituent engagement and stakeholder engagement, let's see if this bill is solving the problems that we're hearing or if we think these problems need to be solved. And then we are going to come back and take more testimony after this bill has been worked on. Mr. Renner?
Madam Chair and members, thank you very much. Dave Renner, today representing the Minnesota Medical Association and also the Minnesota Academy of Family Physicians in strong support of Senate File 278, and I will also try to be brief. As Senator Jensen stated in his comments, when PBMs first came on the scene, they served a purpose. They were there to negotiate drug prices, which we all have great concerns about with manufacturers, and then pass those savings on to group purchasers. The trouble we have today is that it has gotten so confusing how we pay for drugs and how we purchase drugs. And because there is a complete lack of transparency of where that money flows, we cannot be assured that those savings are being passed on to PBMs based on that bargaining clout that they have. In fact, there are some, and I think Senator Nelson raised this issue, there are some who argue that the current system may even be resulting in higher costs for patients. Clearly, PBMs and drug manufacturers are trying to work to try to control costs, and by the use of these large rebates, many times a drug with a higher overall retail price but a larger rebate may get put on a preferred drug list versus a drug that may have a lower retail price with a smaller rebate. It's unclear. Does that happen? We don't know. There's clearly been national stories and studies that suggest that we think that is happening, but again, because of the complete lack of transparency, we don't have a good handle, and I think Senator Jensen's bill tries to at least get at the beginnings of that transparency and that disclosure. Clearly, we hear from physicians and other prescribers that the influence that the PBMs are having it may not always be resulting in the patient getting the best care. Senator Jensen talked about the issues of inhalers. We hear that all the time. And clearly the savings that we may be getting because of some of those changing of drugs are eaten up immediately as soon as a patient does show up at an emergency room and can't get the care they need. So we clearly think that the need for this bill, at least that transparency piece, to ensure that the money flows and the decisions that are being made to determine what drugs are covered are being done for the right reasons. The other concern we have clearly about what happens right now is the patients aren't informed when these changes are made, and prescribers aren't informed. So what may be covered at one time of the year, a month later is no longer covered, and yet then the patient is given a prescription that can't get filled. So for all of those reasons, Madam Chair and members, we strongly support this bill. We'd be happy to work with the author, continuing and work with any of you to hopefully get this passed. I'd be happy to answer any questions.
Thank you, Mr. Renner. Mr. Graves.
Thank you, Madam Chair and members. Thank you for the opportunity to be here today. Bentley Graves from the Minnesota Chamber of Commerce. I want to thank Senator Jensen for bringing this forward and for all those that have participated thus far today. This is a big conversation, and I appreciate the deliberate approach that the committee is taking to it. And giving opportunity for many folks to kind of weigh in with their perspectives here. So I know the time is short, and I'll keep my testimony relatively brief. But I want to thank Senator Jensen. I've had a couple of very good conversations with him just over the last couple of days about this bill, and look forward to continuing those as the bill moves forward in the process. And those conversations centering really on two specific pieces of the bill that we have some concerns about, specifically from the plan sponsor standpoint, one of which is the provision in the bill that would require a PBM to act as a fiduciary on behalf of the plan sponsor. And this is something that I think in general in many ways, to most, would seem to make sense. But I point out that responsibility that a fiduciary has is very, very specific. And in many respects, in these particular arrangements, would really limit the kinds of contractual arrangements that a plan sponsor can come to with a PBM. It's something that the FTC has looked at and found that very same concern, that it would restrict these kinds of mutually advantageous relationships, and also that these changes, albeit well-intentioned, would likely generate more costs without any real benefits. So that's certainly a concern. It also, we believe, would also end up limiting the use of some of the important cost containment tools that PBMs bring to the table on behalf of plan sponsors. So it's something that we've talked a little bit with Senator Jensen about, and will continue to, and again, very much appreciate his willingness to look at that with us. The other piece is the provisions in the bill that have to do with giving patients an incentive to use a mail order outlet or a specialty outlet that a PBM may have an ownership interest in. This too is something that in the past the FTC has looked at and found that PBM owned mail order is generally cost effective for plan sponsors, and that's not just for mail order as well. There are PBMs out there that have also interests, as the bill suggests, in specialty pharmacies or other pharmacies. There is a recently released a peer-reviewed study about a PBM-owned specialty pharmacy having to do with behavioral health, and the results were that adherence for those patients to those drugs was 93%, which is almost double what the industry standard is. And that adherence also brings down costs, and those are documented in the study as well. So, excuse me, that's another piece that we like to continue talking to Senator Jensen about. Again, these two pieces of particular concern from the plan sponsor standpoint, in limiting the ways in which PBMs can be leveraged by plan sponsors to keep costs down, both for themselves and their beneficiaries. So thank you for the opportunity to testify, and look forward to continuing the conversation.
Thank you. Senator Jensen, we have questions from a couple of members, and then will be about time for you to prepare your close. So, Senator Abeler.
Well, thanks, and I wish we had time for more back and forth, but I'm not going to embarrass anybody in the audience or any of the testifiers, but I guess I'll make it a comment. But I've had the privilege to serve in one of these chairs for this my 20th year, and I feel like every one of those 20 years we've been trying to look after what's important to the patients and preserve the doctor-patient relationship. And I feel like we've been throwing pebbles in front of a bulldozer as we've been watching the encroachment of and God bless the plan sponsors, and God bless the businesses who are helping their employees to get the care they need. But at the end of the day, it really matters about how good is it going for the patients. And are there people available in greater Minnesota to look after the needs of the individuals in a face-to-face way? A mail order cannot do that. And I'm really glad we're working on this. And I could spend the next 10 minutes kind of expressing my concerns, but I'm only going to go about 30 more seconds or so. But this is the right bill for the right time. And I commend the chair for allowing it to come forward. There's all kinds of behind-the-scenes stuff. No one has come to talk to me from the PBMs this year to tell me why this bill is a bad idea. It's a great idea. It's what people expect us to do, to look after their protections in a world that's becoming more and more opaque and invisible. And something like this needs to go forward. And Senator Jensen and the rest of you, thank you for that. And I'm not interested in hurting anybody's business. And the PBMs, there's a lot of good things. But every so often, they got to be reined in, and credentialing and licensing and setting standards. And this invisible trolling and clawing back numbers. And for heaven's sakes, there's a balance. And this bill, I hope at the end, can strike that balance. And so I'm all in on trying to make that go. Thank you.
Thank you. Senator Abeler, I'll have Ms. Todd Harlan note that you'd like 10 minutes at the next hearing. So,
Madam Chair.
Senator Jensen.
Thank you, Madam Chair. I'd like to respond to Senator Aber's comment. Thank you very much, Senator Aber. And serendipitously enough, about an hour or two ago, Senator Marty came to me with 4 very thoughtful potential amendments, revisions, areas like that. And specifically to your point, trying to cherish and understand the value that goes on between a pharmacist and a patient, and that a mail order isn't necessarily a substitute. So to Mr. Graves' concern regarding the economic impact, we understand that as well. And I think that is the beauty of the chair's plan to choreograph this in such a way that we have time for stakeholders to come back and talk with us so that we can hammer this out, give it the best shape it can. We'll be back. And in the meantime, I hope that the PBMs are far more enthusiastic about meeting with you and Senator Marty and each one of us, because this is really this is a big bill, and the pharmaceutical industry is a big industry. And I certainly hope that people would reach out to Senator Klein with this expertise, because you need to be involved in all these discussions, Senator Klein. Thank you.
Senator Jensen, we have Senator Kiffmeyer and Senator Klein on our list as well. Senator Kiffmeyer.
I'm just going to do a placeholder. I brought this up before in regards to the formulary, the list of drugs that each plan negotiates for. What is disturbing is that there's a contracted plan, but that patients who oftentimes choose a plan based upon their needed formulary that has their drug on it, midway through or sometime through, it's pulled away from them. And I think we should address that once a contract is signed, and once that is, you can add things, but you can't do that and just take it away from patients. It's a contract, and that contract should go both ways, both to the patient and the doctors who serve them, and so on, and that they can just adjust to it. But I just want to mention that. I brought it up before. I couldn't quite see in the bill as I read it if it's in there, but I think somewhere along the way, maybe you could add that or work with that.
Thank you. And to Senator Klein.
Madam Chair, Senator Jensen, thank you so much for bringing this bill forward, for all your good hard work on it. We heard the perspective from the treating pharmacists about their relationships with their patients, and I know you have many stories as a prescribing physician, and as do I, and I'd like to share a couple, which I think will amplify Mr. Renner's comments. And specifically with regards to rebates and sort of the perverse incentives that they are creating within our delivery system, we have a good but not perfect system of innovation and process in pharmaceuticals in America, where there's a certain period when brand name drugs are protected and are perhaps more expensive to sort of recapture research and development costs, and then they go generic and they become cheaper. Prescribers like you and me see that now there's something that Lipitor was expensive but effective, and now we have a generic, and I'd like to switch you to this, Mrs. Smith. It'll be just as effective, it's much more cheap, and amplified out by thousands of doctors like you and me across the nation doing our civic duty. We're trying to bring down costs and treat people safely and effectively. And yet what you encounter is that the PBMs will have a rebate on the Lipitor, for example, and will want to keep that on formulary and keep that more expensive, sort of outdated drug in the system because they get a rebate on it. So it's disrupting that natural progression that we've established in America to how to bring down costs over time and how to get people more access over time. And so the biggest part of your bill, Section 6, simply asks us to look at that. Let's shine a little light and see. And if the industry ever opposes transparency in what is actually happening, well, that's a huge red flag for me. If we can't at least see what your costs are and where they're going, then there must be something wrong. So thank you for bringing it forward.
Thank you, Senator Klein. And Senator Wicklund, she is the last person on my list, and then we'll let Senator Jensen close. Senator Wicklund.
Thank you, Madam Chair. I just wanted to make a comment, since we are going to revisit more specifically the bill later on, but I just wanted to make a comment. I've been doing some research regarding the huge increases in insulin pricing over the last 10, 12 years. We've seen list prices that are increasing, tripling in just a very short time period, and it's, having a life or death impact on patients. And so my desire in working on this bill with you is that we really start to get at, why are there not more incentives in this system, this whole supply chain, to strive for the best pricing and formulary decisions for patients. And the pricing the bottom line for me is that the patients are not in that position today. They're not looked at as needing the best pricing. They're seeing huge increases in the amount of co-pays and list prices that they're being asked to pay, and it's just not affordable. It's not affordable or accessible. And I think another consideration we need to look at is the social cost to our lack of ability to put pressure on this part of the supply chain in terms of lack of adherence to medication or lack of ability to use the insulin properly causes, more healthcare issues for patients and more costs to our system. And we know that chronic diseases are a huge part of our budget, our healthcare budget relate to chronic diseases. So if we aren't willing to get at this, to find the transparency and look for tools to hold prices down, it's going to affect all of us, and in the immediate term, it greatly affects diabetic patients. So my thought is, as we look at ways to modify this bill, I'll be looking for, how does this work for patients, and how does it best address patient issues? And if there's going to be pushback on some part of the bill not working well or not being feasible, my question is, how are we going to get at this for patients? Because I think we need to start to hold the system more accountable. So thank you for your work, too.
Thank you, Senator Wiklund. Senator Jensen, to close.
Thank you, Madam Chair. I would point out a handout that we did not have time to discuss deals with the concept of spread pricing, and we can talk about that offline if we need to. I want to thank Madam Chair for letting me bring this bill forward early in the session so that we have time to have that robust discussion. I do think it's important that there's no intent here to demonize any one part of this whole supply chain of pharmaceuticals. I mean, as a physician, I know that I play a role also in making decisions that may not always be the best, and I think that we're all learning, and I think that the manufacturers have their own incentives. So, and I also think we can look at the plans and we can say, where have you been in this process? Have you really been incentivized, or have you created the appropriate incentives to make certain that PBMs are playing according to transparent rules? So again, I just want to say thank you for your energetic attention. I look forward to having Madam Chair bring this back from the table down the road, and in the meantime, my door is open. Thank you, Madam Chair.
Thank you. And members, regulating an entire industry is a really big step for the legislature to take. We're going to give this time and thoughtfulness. I know there are a lot of issues around healthcare that this could end up being a vehicle for. I know you will take this work seriously between now and when we take it off the table. We are creating a new section of statute. We are creating a new regulatory authority, which will actually sit in the Department of Commerce. So listen to the problems that may be related to this space, listen to the opportunities, and make sure that the language reflects a solution to those problems or transparency where it's needed. And that's what I'd ask you to do between now and when we take it off the table. So members, with that, Senator Jensen, I'd ask you to move that this be laid on the table.
Madam Chair, I do indeed move that Senate File 278 be laid on the table.
All those in favor say aye. Opposed? Members, Senate File 278 is on the table, and we are adjourned.
Thank you.